managing epilepsy in primary care, is it not only for the specialists? So there are a couple of things. One is about, do we have enough specialists? So, and what about the size of the problem of epilepsy? So as you see, we have an prevalence which varies between, say, about 5 to 10 per 1,000 population, which makes it a total of close to 13 million epilepsy patients in the country. And to manage those, if we are going to rely only on specialists, we have approximately 3,000 neurologists. Not only do we have very few neurologists, we also have them only in very select big cities. Also, we know that not all epilepsy patients actually require very complicated specialist or super specialist care. And almost 70% epilepsy patients are very likely to do very well with just 1 or 2 correctly prescribed anti-seizure medications. Also, this is very recent in 2019 that the WHO has come up with a document about how the problem of epilepsy, especially as it pertains to the low and middle income countries, could be resolved. And it has provided a stepped model of care. And if you look at level 1, this is primary care. And here you could identify symptoms, diagnose the condition, and start treatments. And level 1 care.
Can I interrupt? If you are showing the slide deck, we are not able to see.
Oh, I'm so sorry. Okay, let me go back and try to share once again. Are my slides visible now?
Yes, now.
Okay, I'm so sorry. So like I was telling you, so we have a large patient burden and we have very few doctors. And then this is the stepped model of care that I was talking about. So in level 1 care, you do not have to rely on investigations. It's primarily a clinical diagnosis, which is enough to make a diagnosis and start treatments. So level 1 care can very easily be provided by graduate and postgraduate medical doctors. And in fact, even Ayush doctors can be trained to provide level 1 care. Along with the diagnosis and starting of treatment, emphasis is laid on public awareness of epilepsy and on the social aspects of the condition. And no matter where you take care of an epilepsy patient, you have to be cognizant of comorbidities which might be there, which need to be identified and treated, like in any other condition. So people often wonder and ask, how can I manage epilepsy? I do not have EEG or I do not have imaging available where I'm practicing. So we need to realize that the one tool that you require to make a diagnosis of epilepsy is actually the history. It's not an MRI or a CT scan, and it's not an EEG. So who do you take this history from? You have to be careful that you talk both to the patient and to a reliable eyewitness. So the emphasis is on somebody who has witnessed the seizure themselves. It's very important to know who you're talking to, and that will ensure that you are making a correct diagnosis of an epileptic seizure. Now that we have smartphones, or people have, in most phones, they have videos. So if you see a patient and either, for lack of an eyewitness or any confusion in the description of the event, you can rely on home videos, which is a good way of ensuring, whether the event that is happening to the patient is an epileptic seizure or not. But then once you diagnose an epileptic seizure, it does not automatically become a diagnosis of epilepsy. So a person may have an epileptic seizure, but they may or may not have epilepsy. So how do you diagnose epilepsy? Once you're sure that a person is having events which are epileptic seizures. So there are three ways. This has been laid down by the International League Against Epilepsy in 2014. There are three ways in which one could diagnose epilepsy if the patient is presenting to us with events which we have confirmed and we feel that these events are epileptic seizures. So if a person comes to you and they have already had 2 or more unprovoked seizures, epileptic seizures, which have occurred more than 24 hours apart, then this person is diagnosed to have epilepsy. Most patients will fulfill this definition criteria. So actually the other two I will mention, but I think if you understand this way of diagnosing epilepsy, you will probably not miss most patients. So if a patient has presented to you with events, on history, you have made sure that these events are epileptic seizures, and the patient has had at least 2 such events which have happened more than 24 hours apart. Then a diagnosis of epilepsy, a clinical diagnosis of epilepsy can be made. The other 2 ways in which you could also make a diagnosis is in people who have a person who has presented after the first unprovoked seizure. Here too, in some patients, you can, even after the first event, make a diagnosis provided you rate the risk of a seizure recurrence as being high. So you might ask me, how do you rate the risk? So that would depend upon a combination of history. For example, if there are close relatives, first degree relatives with epilepsy, if on history you get history of some epilepsy risk factors, for example, history of head injury in the past. On examination, you have some focal neurological deficits and you think this person is likely to have a second seizure, or then there are clues in investigations. So I'm not laying a lot of emphasis on this second definition or the way to diagnose epilepsy, because sometimes imaging and EEG may not be available, and so there may be a difficulty, and it doesn't matter if you are going to wait for the second seizure. That is fine too. And the third way to diagnose epilepsy is, even after a first seizure, you recognize a syndrome. This again, for now, I'm just going to leave it aside. So basically, the way to diagnose epilepsy is to first categorize the patient, the event which has happened as an epileptic seizure, and if 2 such events have happened, then you are correct in making a diagnosis of epilepsy. Once you say that this person has epilepsy, which means that they are having recurrent epileptic seizures, at least 2 have already occurred and more are very likely to occur, then the rest of the history needs to focus on taking a history of epilepsy risk factors, because these risk factors will decide or give you a clue as to what may be causing the epilepsy in this patient. And also in differentiating, focal onset epilepsy or focal onset seizures rather from generalized onset, this distinction becomes the anti-seizure drug. So the other relevant history that you might want to know is about the birth and development. Was there any complications at the time of birth? Did the patient or the person have a normal development as far as their milestones were concerned? Were there any febrile seizures in childhood? These can be a precursor of epilepsy in some patients later in life. So this history is important. Is there a family history of epilepsy in any first degree relative? This is important. It's very difficult to get in most patients, sometimes because they are unaware, and sometimes because of the immense stigma attached to epilepsy, people may be reluctant to talk about family members being affected. But anyway, you do need to make an effort. Any significant head injury in the past, this too is important. any CNS infections, meningitis, encephalitis in the past, and any other neurological disease. So if you get a good history and cover all these, you're very likely to figure out in a lot of patients as to what could probably be causing epilepsy in this particular patient. Then again, with this intention of wanting to differentiate focal onset seizures from generalized onset seizures, you have to ask about the seizure per se. What is happening in the seizure? And you ask about pre-ictal, ictal, and post-ictal phases, which means what happens immediately before the seizure, what happens during the seizure, and then what happens after the seizure. Before the seizure, you are very interested to find out about aura. Now, this is extremely important because if you are able to elicit the history of aura, you also are able to confirm just from this piece of information that the seizures happening in this person are of focal onset. In other words, his or her epilepsy is a focal epilepsy. Similarly, for Todd's palsy, this is not a very common occurrence, it's rare, but if a patient tells you that after the seizure, a particular limb becomes weak, then, and this weakness generally recovers in a few minutes, this again stamps the seizure as well as the epilepsy as focal seizure and focal epilepsy. So getting a history of aura preceding the seizure, any kind of focal deficit weakness which occurs once the seizure stops, these are both important and they will both help you understand that the person's seizures are of focal onset. Then you also have to ask what happens during the seizure, which is the seizure semiology. And if the patient becomes unaware or loses consciousness during the seizure, then this part of the history will, of course, only be provided by a good eyewitness that you are going to talk to. So then after you have taken these this description of this, what is happening in a person's seizure, what if a person is coming to you, after the first seizure, which has happened in hypoglycemia. So the person had low blood sugar and they had a first seizure. Is this epilepsy? No, this is not epilepsy. This is what is called an acute symptomatic seizure, or it's also called a provoked seizure. So hypoglycemia here is a provocation. It kind of irritates the brain and it causes a seizure. So this is a provoked seizure, and epilepsy consists of unprovoked seizures. So a person who has a seizure as a consequence of hypoglycemia does not have epilepsy. They have provoked seizures. You just correct the hypoglycemia, they will not have seizures anymore, and you do not need to prescribe long-term anti-seizure medication to such a person. These are some other causes of provoked seizures: alcohol intoxication or withdrawal, acute stroke, febrile seizures, where a seizure is provoked in a small child just because they are running fever, acute head injury, which means that a person suffers a head injury and they have a seizure either immediately or within the first week. These are likely to be provoked seizures, whereas seizures which happen later, say 3 months after somebody has sustained head injury, that is classified as post-traumatic epilepsy. But if a seizure happens at the time of a head injury, it's not epilepsy, it is an acute symptomatic or a provoked seizure. And there can be metabolic causes of acute symptomatic seizures like hyponatremia, low magnesium, low calcium, hypoglycemia, hypoxia. So all these seizures are in response to a provocation. They do not constitute epilepsy. And all you need to do is correct the underlying factor if it's a metabolic defect, and understand that these seizures will remit with the correction of the acute insult. So just a few words about febrile seizures, which as I just mentioned, is a provoked seizure. These are very brief, symmetrical seizures and generally happen between 6 months and 6 years of age in children who are otherwise normal. And they're not an abundance of seizures in these children. They may happen once or twice, and you generally do not need to do any tests. Neither do you need to prescribe any anti-seizure medication. All you need to do is reassure parents, and as the child grows older, these seizures remit. What about non-epileptic seizures? So these are different. These seizures are non-epileptic. They have different causes, and they should not be treated with anti-seizure medication. There could be of many kinds, different causes. So one of the causes, for example, vasovagal syncope. A child is standing in the assembly, they may not have had breakfast, they stand for a bit, they feel lightheaded, and they fall, lose consciousness and fall. And the moment they fall, they immediately regain consciousness and they're up on their feet. They do not have a prolonged post-seizure drowsiness or confusion. So this is a vasovagal syncope, which is a non-epileptic seizure. Also, we know seizures which are sometimes called pseudo seizures, but are better called psychogenic non-epileptic seizures, which are not epileptic seizures. Here, generally, there might be some comorbid depression, anxiety. There may be some secondary gain. A child not wanting to go to school, for example, because of some examination, or some domestic, kind of falling out with your relatives and throwing a tantrum kind of a thing. So, I mean, just seeking attention, basically. So these are psychogenic non-epileptic seizures, and these also need to be picked up on history. There is no test that you can do and confirm, rule in or rule out psychogenic non-epileptic seizures. It is based entirely on history. So the history is a very, very important tool in both diagnosing epilepsy, also in ruling out acute symptomatic seizures and psychogenic non-epileptic seizures or any other non-epileptic seizures. So once you have made a diagnosis of epilepsy, then there is a little classification that is relevant to management. So I will not go into details of classification. I will only tell you as much classification as you need to know to decide on treatment. And this can be done clinically. So you do not worry about not having investigations in case you don't. And you need to broadly classify the seizure into either being focal onset or generalized onset. Sometimes, in spite of making a lot of effort in taking the history, you may not, on the first instance, be able to decide is it focal onset or generalized onset, and then you may label the seizure as being of unknown onset. If a seizure is of focal onset, it can be further classified in several ways. One of the ways could be based upon awareness. So does the patient remain aware during the seizure, or does the patient have impaired awareness? That is one way of classifying focal onset seizures. The other way may be, are the focal onset seizures motor or are they non-motor? Further, focal onset seizures could either remain focal or they may spread and become bilateral tonic-clonic. So in all of these, the important thing to remember is that the onset is focal. And even if the seizure becomes bilateral tonic-clonic seizure, after having a focal onset, you will still classify it as a focal seizure. And if the patient is having only such seizures, then that patient has focal epilepsy. And the treatment will be selected accordingly. Similarly, generalized onset seizures can also be either motor or non-motor. So you make a diagnosis of an epileptic seizure, then you make a diagnosis of epilepsy after having ruled out acute symptomatic seizures and non-epileptic seizures, and then you classify the seizures into focal or generalized onset. Sometimes the onset may be unknown. Now, the question about investigations. Do all patients need investigations? So I should tell you, what do investigations do in epilepsy patients? What are we looking for when we are doing investigations? One is that the investigations support the clinical diagnosis. I've already discussed as to how you make the clinical diagnosis, primarily using the history. So investigations may just be used to support clinical diagnosis. You may also end up finding out what is causing the epilepsy through the investigations. But you may also find that, if you've taken a history and you are getting some clues as to what is causing the epilepsy. For example, in a patient who has had a severe head injury, probably that is what is causing the epilepsy. You may further confirm it by imaging and seeing some damaged tissue in the brain. You may suspect that the patient is having epilepsy as a consequence of some birth injury. There was history of delayed cry at birth. The imaging in this patient will only confirm your doubt. You will see brain damage consistent with birth hypoxia at birth. So the investigations can tell you a little about what is causing the epilepsy. And finally, this distinction between focal and generalized. So the distinction between focal and generalized can also be made clinically, and investigations may further add information in the same direction. So all of this, diagnosing the epilepsy, uh, also arriving at a possible cause, and differentiating focal from generalized epilepsy can all be made clinically. Tests can only confirm what you may clinically suspect. So this, I will just show you, was a study in about 500 patients done here at our department. And in 500 patients, 2 investigators were, they tried to classify the patient's epilepsy into focal or generalized. One investigator did this based only on clinical history and examination. And the second investigator also had test results of EEG and imaging of the brain. And we found that in almost 97% of the patients, both the investigators, whether they used only clinical history examination or they had additional input from investigations, they arrived at the same diagnosis of classifying the epilepsy into focal and generalized. So this is just to show you that you do not need to feel very worried if you do not have investigations readily available to you. Take a good history, and in most patients, you will not be wrong either about your diagnosis of epilepsy or about your classification of this epilepsy into focal or generalized. And in this study, we had found certain factors which predicted, whether the person has focal epilepsy or generalized. And focal epilepsy was predicted by the presence of an aura, which you're going to get in the history. If in the seizure semiology or the description of the seizure, there was an account of head version or turning of the head during the seizure, then the epilepsy was more likely to be focal. If the patient was younger, 10 years or less, and if there was a history of delayed milestones, all of these were very closely or significantly associated with focal epilepsy in the patient. Whereas patients who had generalized epilepsy, you were more likely to get a history of myoclonic jerks and seizures happening mostly on awakening in the morning. Okay, now specifically, what is the role of EEG? A lot of people, they think that you do an EEG and you get to know whether the person has epilepsy or not, and that is absolutely not true. The diagnosis of epilepsy remains clinical. An abnormal EEG will only confirm this diagnosis. And it will not confirm it in every patient. For example, almost half the interictal EEGs, the EEG that you normally do in a patient of epilepsy, is not during the seizure. It is after the seizure, between 2 seizures. And this is called an interictal EEG, and it is normal in up to 50% of the patients. So it's only when you get an abnormal EEG that you will be able to confirm the diagnosis. If the EEG is normal, as it is going to be in half your patients, it will not add anything to your diagnosis or would not provide any confirmation of your diagnosis. Then Interictal abnormalities, if they are there and if they are focal, well, then they confirm that the epilepsy is focal. If they are generalized, then it confirms that the epilepsy is generalized. But like I was telling you, these abnormalities are only seen in 50% of the patients in one interictal EEG. So there's really no big need for doing an EEG. And if you get a normal EEG, it definitely does not rule out epilepsy. Because, like I said, half the patients will have normal interictal EEGs. So an EEG does have use, but in primary care, not much is lost if you do not do an EEG. And in fact, doing or getting an incorrectly done EEG or an incorrectly reported EEG probably is going to create far more confusion than it's going to help you with your patient management. Similarly, what about brain imaging? So why do we do brain imaging? In patients with focal epilepsy, you can see what is causing the epilepsy in a patient's scan, be it a CT scan or an MRI. But what if this imaging is not available as it can be in primary care? Well, if you have made a clinical diagnosis of focal epilepsy, you can start treatment, even if you do not have an imaging and you cannot see what exactly is causing this person's epilepsy. You can definitely start treatment. The other question also is, people ask, should I do a CT scan or should I send a patient maybe 200, 500 kilometers for an MRI? So it should be, everyone agrees that an MRI is a gold standard for epilepsy. But the question is, what kind of epilepsy management are we talking about? If you're talking about specialist epilepsy management, well, yes, you might require an MRI. You're trying to look for lesions, for example, in patients who have drug-resistant epilepsy to see if there's anything which is operable. So you definitely cannot have anything less than an MRI in such a situation where you're doing a tertiary care or quaternary care epilepsy management. However, in primary care, you are not looking to operate patients. All you are looking to do is rule out a serious or a treatable lesion. So in primary care, a CT scan would generally be sufficient, because with a CT scan, you will be able to rule out both a serious lesion, for example, a tumor, or a treatable lesion, for example, a tuberculoma. So if you have a CT scan, which is easily available, and of course it comes at a lesser cost, you should definitely prefer to do a CT scan in patients with focal epilepsy. In generalized epilepsy, if you're clearly diagnosing a generalized epilepsy, then the imaging is going to be normal. So not much will be added by doing an imaging in a patient where you are confident about a clinical diagnosis of a generalized epilepsy. However, you urgently need imaging in certain situations, and those are listed over here. If there is recent onset seizures, especially if they are starting late in some patients, in an older patient. So recent onset seizures, if there's a focal deficit, you definitely require to image the patient very urgently. If there are features of raised intracranial tension, or if you think there's a high risk of an intracranial lesion in a particular patient. So these may kind of, even if the patient has to travel, which may be not very easy or it may cost money, yet in these conditions, it is preferable that imaging be done urgently. So after making a clinical diagnosis of epilepsy and ruling out acute symptomatic seizures, non-epileptic seizures, after making a distinction between focal and generalized epilepsy, now you want to start anti-seizure medications. So the ground rules are basically, you confirm the diagnosis, you confirm focal or generalized, you consider the patient's age and gender before you start the drug, you look for any comorbidities. You also try to see if the patient is more susceptible to any anti-seizure medication side effects. For example, a person is already overweight. You may want to, avoid certain drugs. And then very importantly, what is the socioeconomic status? You need to keep that in mind every time you're starting treatment, because this treatment is going to continue for several years. So there's no point writing a drug for a patient who's not going to be able to afford it. And then how do you start? So this is extremely important. You do not ever start epilepsy treatment with more than one drug. A person comes to you with their first seizure or the second seizure, you don't need to write 2 drugs or 3 drugs on the first day itself. Start with one anti-seizure drug. Now, you are going to start on one drug because you have diagnosed epilepsy. However, you need some more information if you want to be correct in your choice of the anti-seizure drug. And what all should you consider? So we have already seen that you have to be thinking about whether the seizures are focal or generalized, and whether the epilepsy is focal or generalized. You also have to consider what comorbidities does this patient have. For example, a patient is diabetic, or a patient is also has migraine, headache. So you may want to choose a drug which will work for both in such a patient. A patient has got diabetes. You may not want to prescribe a medicine which will cause too much weight gain. So looking at comorbidities or considering comorbidities before you start treatment is very important. You also will think about etiology. What is causing seizures in this patient? What is the cause of his epilepsy? It is important to consider this because, if you know this is a structural lesion, for example, if you think this is a calcified lesion, you may have done a CT scan, which is the best tool for picking up a calcified lesion. Then you know that if after starting one drug, maybe adding a second drug, the patient does not become seizure-free, then this may be a surgical candidate. Versus another patient who, for example, if they have some other etiology, a genetically determined epilepsy, for example, a generalized epilepsy, this person is not likely to become a surgical candidate. So just thinking a little about what is causing the epilepsy in the patient and what are the comorbidities is important at the time of starting treatment. So like I've already told you, you will look at, the seizure type, the epilepsy, the age of the patient, gender, etc. If patients have had previous exposure to anti-seizure medication, and they can tell you about it, very good. Very often our patients don't know. If you ask them, yes, they have taken medicine sometime in the past, but they're not sure what it was. They don't carry any old prescriptions and they don't remember the name of the drug. But, you can ask the patient that whatever that drug was, did you have a drug-related rash? This is important to ask because if a patient has been exposed to a drug, has had a drug-related rash, and you inadvertently re-prescribe the same medicine, then they may have a more serious kind of a complication, drug-related complication. So to avoid that, you should, in every patient that you're starting treatment, ask if they have previously had any anti-seizure medication-related rash. Also, you have to consider lifestyle. For example, somebody is a student, and if you write a sedating medicine early in the morning, the child is going to keep sleeping in class, and that would his schooling would suffer. So look at what the patient does. When does the patient need to be very alert, awake? Do they have a mostly sedentary lifestyle, or are they very active? So all of this will kind of help you select the appropriate drug. Do they have any personal preferences? So a shift worker, for example, might tell you that I only get to sleep during the day. So your strategy for prescribing for this person may be slightly different. Look at their personal preferences. And extremely important, I can't emphasize this enough, do consider the cost of the drug in the context of what the patient earns, what money does he have to spend on the treatment. Now, see, this is a lady who has got extensive gum hyperplasia because she was prescribed phenytoin. Phenytoin is not to be used for girls or young women. It causes a lot of coarsening of facial features, hirsutism. Of course, it causes gum hyperplasia too. So consider the gender. Phenytoin, not a good drug for women. And if you specifically want recommendations as to which drug would work for which kind of epilepsy, in focal epilepsies, the gold standard still remains carbamazepine. Oxcarbazepine also works as well as carbamazepine. They are related drugs. So oxcarbazepine or carbamazepine would be a good choice for focal epilepsy. For generalized epilepsies, the drug of choice would be sodium valproate. The concern is using it in women because of its teratogenic potential. So, however, if you use it in small doses, because this teratogenicity is dose related, so say about a total dose of 600 to 800 per day will be all right. Relatively, if you have to write sodium valproate, you may use it in moderate doses. And do not forget to add folic acid. It is important to remember that carbamazepine can worsen generalized epilepsy. So, this distinction between focal and generalized is important so that not only do you select the correct drug as per the kind of epilepsy, but you also do not wrongly prescribe and worsen epilepsies by writing the wrong drug. Sometimes, if you are unable to make the distinction between focal and generalized, or these older drugs, they are extremely effective, but there are some problems with them in terms of maybe long-term side effects or interactions. If a person is taking some other drug for some other condition that he may have, then you may have to select levetiracetam. The benefit is levetiracetam is a broad spectrum drug. It works for both focal and generalized epilepsy. It generally has a very limited interaction with other drugs and also is relatively side effect free. Other than some behavioral side effects. However, levetiracetam is much more expensive than either carbamazepine or sodium valproate. So keep that in mind. If the patient is able to afford levetiracetam, definitely you can use this drug both for focal as well as for generalized epilepsy. What about phenobarbital and phenytoin? Now, these are older drugs. They have been used for very long, much longer than the newer drugs. But like in all other drugs, there are pros and cons to prescribing phenobarbital and phenytoin. So they are very inexpensive, both these drugs. They can be given once a day. So that is a kind of an advantage. And they are quite widely available. However, they do have serious long-term side effects. They are enzyme inducers, very strong enzyme inducers. And specifically with phenobarbital, even with one missed dose, the person can have very serious breakthrough seizures, even status. So these things need to be kept in mind. Once in a while, you may still have to prescribe phenobarbital and phenytoin. However, if you can avoid it, it would be very good. You could use the other drugs, that I mentioned, carbamazepine, sodium valproate, or a broader spectrum drug like levetiracetam. Now, generally, a dose range is given. For example, 10 to 20 milligram, 40 to 60 milligram. So, how much should you push the dose? So, we do have evidence that in almost half the newly diagnosed patients, 90% or more will do well at moderate or even modest, which means lower, or say the median doses would work well for most patients. And so there is generally no going on pushing the dose of the drug and, causing side effects in the process. Generally, patients, if they have to respond to a drug and it has been correctly chosen according to your diagnosis, the seizure type, the syndrome, or the epilepsy type, then the patient is going to respond to the median dose. Most patients are going to respond to the median dose. And I want to only, I want to emphasize this about how do you start carbamazepine, because it is going to be a widely used drug for focal epilepsy. It is a very effective drug, but you have to be very careful when you start it, because starting it at full dose is ensuring that the patient is not going to take it. It causes very severe toxicity if drug levels they rise up abruptly in a short time. So you have to gradually increase the dose every week. So whatever strength you're using, 200, 300, or 400, you start it with only half a tablet in the first week. In the next week, in the second week, you add another half a tablet. And in the third week, you give half and one. And only in the fourth week, you reach the full dose of 1 tablet BD. And you specify, of course, for all drugs, the time at which the patient should take it. And extremely important for all drugs, but very, very specially for carbamazepine, because most drug rash probably in our patients we see with carbamazepine. You don't only tell the patient to be careful about drug rash on starting treatment, you also write it on your prescription for your own safety. Patients may forget that they were cautioned, or they may deny they were cautioned, but if you have documented it on the prescription, then it's difficult to contest that you've done that. So be careful about starting carbamazepine on a small dose and gradually escalating the dose. And the time when you are going to be giving the prescription, you have to give some information to the patients. Otherwise, just handing over the prescription without talking to the patient is really just half the treatment being done. So you explain the disease. Very, very important, explain the prescription. If you just scribble something and hand it over to the patient and assume that they're going to follow it, 9 times out of 10, they are unlikely to even understand what they're supposed to be doing. And, the drugstore chap is going to be telling them anything and they will just follow, and which will generally not be the correct thing. I've already told you to caution patients about drug rash when you're starting treatment, emphasize compliance, remind them to fill prescriptions before they run out of drugs. This happens often in patients who live in villages. I've seen in small towns where drugs are not available sometimes. So if they wait for the last tablet to run out, then, for a day or two, then they miss the drugs and have seizures. Patients often ask, have I got to take it before the meal, after the meal? So it is important to take it at a fixed time. If a patient tolerates the drug on an empty stomach, it is better absorbed. But if, they have some discomfort or they do not tolerate, then they can take it after the meal. The important thing is that you have to have a fixed time to take it in the morning and evening to ensure that you don't forget or don't miss the dose. Patients should be told, in case of intercurrent illness, what if, they had fever and they have to take some other drug? Very often patients think that the seizure medication should be stopped. That is not true. So you should tell the patient this when you're starting treatment. And patients may or may not ask, but often they do wonder, for how long is this treatment going to continue? So we, need to make it a habit to not give predictions at the time that you're starting treatments. You need to tell the patient that this treatment is for some years. And at the time of starting treatment, it is very difficult to be certain as to how much time this treatment is going to be required. So if you're going to, I'm so sorry for that. So if you're going to make a prediction about the duration of treatment, you are very likely to be wrong. So I would say desist from it. It's better to tell the patient it's a long duration treatment, and we will know more as we go along. Because if you do well with the drug, we might, be able to stop it in a shorter time. However, if you, have seizures even after treatment, it may have to be given for longer. And then you must check if the patient has any other questions, and you should answer those too. Most often patients are dissatisfied if, We do not address any of their concerns, don't talk to them, don't explain them anything, just hand over a prescription. Then you can imagine the anxiety that they are carrying and all the misinformation that surrounds them. So to ensure, your patient doing well on your treatment, which is extremely important, the best way is that please, as much as possible, inform them what is happening and how is it going to be going forwards. Now, a special, this situation, a patient has a seizure, was doing well for 5 months, and then suddenly comes with a seizure. What do you do? So the reflex reaction should not be to just start increase the dose. That's not what you should do. There are a lot of things which you need to check. So, for example, you should consider your diagnostic accuracy. Was this patient that you're treating, does he really have epilepsy? That is also an important question. So further go back to your history, if available, look at the videos. Okay, fine, you're sure this patient has epilepsy. Ask about compliance. It's very likely, patients often miss 1 or 2 doses and even forget about it. So go back and check compliance. Had the patient taken the medicine or not? If you have instructed patients to keep a seizure diary, that's an excellent way for them to keep track and for you to know what is happening to the patient. Then maybe the patient had, for example, fever, and somebody could have just prescribed a quinolone. So that quinolones, they lower seizure threshold. So ask the patient, you were compliant, but did you take any other medicine? And you might find that, well, they did, and that could have caused the seizure. If you are able to ensure that none of the above has happened, it's only then that you think about either increasing the dose, or maybe if you have already given the maximum dose, maximum tolerated dose, you might want to either add or to change the medicine of the patient. So the reflex response to every seizure that's happening in a patient should not be to just immediately jump and add another drug or to increase the dose, but to check for the rest that I've mentioned before you decide to increase the dose or add another drug. And what do you do when the first drug or a monotherapy that you have given, it fails? So if your patient tolerates monotherapy with the first, second, or third drug, so you have tried 3 drugs sequentially, not together, in monotherapy, the patient has tolerated the treatment, but has had suboptimal response, which means that the seizures reduced, but they did not totally become seizure-free. Then this may be a patient who may be a candidate for addition of a second drug or a combination therapy. So if 1, 2, or 3, the 3 choices of monotherapy that you have tried in appropriate doses, patient has been compliant, you're confident about that, then maybe it is a time to give a combination therapy. More than 2, anti-seizure medication, I would not recommend for in primary care. If a patient is not doing well on 2 drugs, it may be better to refer the patient for specialist care, for better evaluation, investigations, etc. So just piling 1 drug on another and reaching 3, 4, 5 drugs will not benefit patients. So remember, you should rather try 2 or 3 drugs in monotherapy in correct doses. And if that doesn't work, you can add a second drug, but beyond that, increasing the number of drugs in primary care may not be advisable. And then such a patient, their seizures may be controlled. Of course, then they're going to be visiting you for follow-ups over several months, years rather. So what do you do at each visit? You continue to look for seizure control, insist that the patient maintains a seizure diary so that they and you both know whether seizures are happening or not. Patients often forget about seizures. And without a seizure diary, it's very difficult to know whether the seizures are controlled or not. Then you look for any drug-related side effects. You must screen for mental health issues. We know that, up to 1 in 2 or 1 in 3 epilepsy patients have either depression or anxiety. if you can just quickly screen for this, and if it's there, it needs to be treated. If you just concentrate only on the epilepsy and do not consider anything else, then the patient, probably the quality of life of the patient is not going to be very good. Any other comorbidities should also be addressed. A patient with epilepsy can have hypertension, diabetes, etc. So you need to be aware, and at follow-ups you need to screen for that. And you must also at every visit ask the patient if they have any new problems. I must tell you this has been provided by one of my residents, and I think it was a good thing to tell you. In patients sometimes who have clusters of seizures, so that they don't just have one seizure, but generally, even if they're having one seizure in 6 months or one seizure in 3 months, they tell you that every day or every time I have a seizure, I have 2 or 3 seizures one after another. That's called a cluster. In such patients, we have intranasal midazolam available in the market, and it is available in 2 strengths. In one of them, each puff has 1.25 milligrams, and in the second, each puff has 0.5 milligrams. So the target dose is 0.2 milligram per kg, and you need to see the weight of your patient. In adults, you may require 8 to 10 puffs of this strength, 1.25. In children, 4 to 5 puffs may be enough. So based upon the weight of the patient, in those patients who have seizure clusters, there is not much use of recommending it to patients who have single seizures, because by the time they're going to go looking for the midazolam spray, get it, the patient's seizure is most likely going to be over. So if the patient has very prolonged seizures or they have seizure clusters, then in follow-up, this is one drug which can be prescribed. If the patient does not become seizure-free on treatment, then and you are going to think about drug resistance. Before you do that, you have to, this is a repetition, that if the patient has focal epilepsy, you should have tried either carbamazepine or oxcarbazepine. If the patient has generalized epilepsy, then you should have tried sodium valproate before labeling the patient as being drug resistant. And levetiracetam, of course, could have been tried in both. So you have to, give a chance to these drugs in these specific epilepsy types before you, declare the patient to be drug resistant and think of referring them. If there is a need for a second drug, I told you that you have given first, second, or third drug in monotherapy. The patient is tolerating them, but the seizures are suboptimally controlled. What should you do? I said you can add a second drug. What should this drug be? This drug should be clobazam. It is a very effective drug. It can be given in a single dose of about 10 to 20 milligrams in the evening. It is a sedating drug. That is the one, a very serious or a nuisance kind of a side effect that it has. It makes patients feel sleepy. Reassure the patients, don't start with 20, start with 5 or 10 milligrams based upon the weight of your patient. In adults, 10 milligram is all right. In children, you may start with 5. And it should only be given in the evening, along with the evening dose of the other drug that you might be using. You should caution the patient that it may cause a little extra sleep. But, this sedation that the patients complain of is generally only for the initial, say, a week or 2 weeks. And generally, patients get used to it. So this is an excellent second drug to add if the patient has not become seizure-free with the first drug. And when do you consider stopping treatment? So, there is no definite kind of a recommendation, but in focal epilepsy, it will vary from patient to patient, but at least 3 to 5 years seizure-free is recommended in focal epilepsy. In generalized seizures, for example, juvenile myoclonic epilepsy, at least 8 to 10 years seizure-free is recommended. So do not prematurely stop treatment. The patient is seizure-free for 6 months, 1 year, you stop treatment, and very promptly the patient is likely to have a seizure recurrence. How do you, of course, it should be a shared decision between the patient and the doctor, and you don't abruptly stop the treatment, you gradually taper it. Now, who to refer? I think in the last few minutes of my presentation, who to refer? If you cannot, after doing all that I have already told you, if you cannot control seizures within 2 years, if the patient does not become seizure free even with two drugs, I told you adding more than that in primary care may not be advisable. If it's a very small child, then you may want to refer it. If the patient is experiencing unacceptable side effects, if there's a structural lesion, you did a CT scan and there is a unilateral lesion, this patient may be a candidate for surgery. If they're not getting controlled, then refer them for surgery. If there is significant psychological or psychiatric comorbidity that you're not able to handle, then do refer. Or if you have a diagnostic doubt, then of course you would have to refer the patient for specialist care. And the most common error that I feel that is made is that we do not talk to our patients. So that I think should be emphasized, that give the patient a prescription, but please explain the patient your prescription and everything else, and also answer whatever questions that they may have for you. And finally, do not co-prescribe. So you prescribe carbamazepine, for example, in this patient, which was costing 200 per month, but the citicoline piracetam, which was also prescribed, that cost 3,000 per month. So while we are so cognizant about the cost of treatment, it really doesn't help if you co-prescribe. This patient has got 1 or 2 anti-seizure medication, but a whole list of things which are just tonics, etc. So avoid writing anything which is not absolutely necessary and not evidence-based. For example, antioxidants, vitamins, they only add to the cost and they do not improve outcomes, and they also lead to non-adherence. So I think with that, I will end. I'm sorry if I've overstepped my time. Thank you.
Thank you, Dr. Mamta. It was a very insightful presentation and an eye-opener for many of us here. Thank you so much, ma'am. Can we move on to the questions now?
Yeah, sure.
This is from Dr. Alicia from Gudalur. Is phenytoin-induced ataxia an indication to discontinue and start a different medication?
Definitely. So this is a good question, because I can address the issue of unacceptable side effects, not only ataxia in the context of phenytoin, but any other side effect. If it is severe, it is an indication to stop the treatment. Of course, check that you're not overdosing the patient. So if you're overdosing the patient, then just a reduction in the dose may be enough. In carbamazepine, for example, it can happen that a patient may be doing well on 800 milligrams per day, but if you make it 1,000 and they come back and tell you that I have diplopia. So unless you are giving a dose more than what is tolerated, in median doses the patient is having serious side effects, please stop the drug and try another one.
This is from Dr. Kaushik Nath from Jorhat. Patient with jerks and normal EEG, how to proceed in such situations?
So I think when he says jerks, he means myoclonic jerks. So he says that the patient has jerks, but the EEG is normal. So I have just told you that in 50% of the patients, the interictal EEG is normal. No. So that is not only in the context of myoclonic jerks, but any focal seizures, generalized seizures in any epilepsy patient. In half of them, the interictal EEG may be normal. So you need to rely on your clinical diagnosis. If you're convinced that the patient is having myoclonic jerks, then it would be advisable to start treatment, even if the EEG is normal. Yeah.
Okay. This is from Dr. Revati Nair from Varanasi. Very rarely, blood donors who have no history of epilepsy develop seizures when they come for donating blood. Are they actual seizures or pseudo seizures?
So you said in blood donors, right?
Yes, ma'am, blood donors.
So a lot of patients, you might have heard from a lot of people that, I saw blood. So maybe blood was being drawn for an investigation, or like in this person's story that they, somebody who's donating blood in the blood bank probably. So the sight of blood sometimes causes a person to just lose consciousness, and then they very quickly regain consciousness. So that's a syncope. It's not really a seizure. So this is not a pseudo seizure or a non-epileptic. This is a syncope. So it is not epilepsy, and you do not need to start anti-epileptic treatment in such a patient.
Okay, ma'am. This is from Dr. Jace Mary Joy from Jodhpur. Can childhood epilepsy occur again in adulthood?
So I had mentioned during the course of my presentation that sometimes febrile seizures in childhood may remit, and then once the patient is older, they may once again start having seizures, unprovoked seizures. Febrile seizures, like I told you, is a kind of provoked seizures, but sometimes in patients who may have had febrile seizures as a child, later in life, they may have epilepsy. So not all childhood epilepsies which remit are going to recur later in adulthood, but sometimes it can happen.
Okay. This is from Dr. Damodar Lily, Mumbai. In the case of absence or denial of a history, how do we diagnose epilepsy with simple tests?
In the case of absence
or denial of a history.
Okay, well, if the patient is denial of history and you are strongly suspecting epilepsy, I don't understand the context, because I assume the patient has come to you. So what have they come to you for? So if they have come to you to just deny a condition, it seems, I don't know. Anyway, so suppose, there's a particular patient and you suspect that they have epilepsy, you're not getting a very good history. You can do investigations, EEG, and you can do imaging. If you find a normal EEG, you cannot rule out epilepsy. The person may still have epilepsy. If you do imaging and you find an incidental calcified lesion, you can still not be sure whether the person has epilepsy. So the diagnosis of epilepsy essentially starts from the person having a seizure. And that is a clinical event, and that is something you elicit in the history. Now, if the patient is saying that they don't have any seizures, then I don't know why you want to pursue them, and want to rule out epilepsy in the first place. Maybe I'm not understanding his question. I don't know.
Okay. Okay. This is from Dr. Devi Shankar Karpaya, Nellore. Nocturnal epilepsy, how to know and how to treat it?
So nocturnal epilepsy, how to know? I think the person is asking because very often the person who has the seizure in sleep, they may not wake up, during the seizure, and only the next day, sometimes they find that the tongue is bitten on the side, which kind of, so they wonder why there's a tongue bite. Sometimes they have wet their clothes, they may have been incontinent during the seizure. So the next day in the morning, and sometimes if there is somebody else in the bedroom sleeping with them, then that person can, generally tell that, well, in the night, this is what has happened. So nocturnal seizures happen. In some patients, the seizures are only nocturnal, and either patients may have sustained injury during the seizure, or a bed partner may tell you about the seizure. So these seizures can be diagnosed and treated with anti-seizure medication.
Okay. This is from Dr. Kishan Mawani from New Delhi. If a patient is having hypertensive encephalopathy-induced seizure, how to approach such patients?
So this is a very good example of an acute symptomatic or a provoked seizure. So if a patient has hypertensive encephalopathy, it is just like a patient having hypoglycemia or hyponatremia or hypoxia. So you have to just treat the hypertensive encephalopathy per se. You do not really have to give long-term anti-seizure medication to such patients. Their seizures will not recur. Once, over a week or 2 weeks, their hypertensive encephalopathy settles, then their seizures will also remit. So this is not epilepsy. This is a provoked seizure or acute symptomatic seizure.
Okay. This is from Dr. Amit Anand from New Delhi. patient with recurrent seizure in alcohol withdrawal. Is any antileptic medication required?
So this also I had covered in my presentation that these are acute symptomatic seizures and they will not require long-term anti-seizure medication. You may, if the patient is having too many seizures, you may for a short while give them anti-seizure medications in the hospital, but longer term, they don't require anti-seizure drugs.
This is from Dr. Deepak Chandra Badani from Bilaspur. What are the basic things about epilepsy management that a healthcare worker working in a remote area must know?
So I think I was trying to talk in the last hour. My entire presentation was keeping in mind this healthcare worker who is in a place where no investigations are available. So familiarizing oneself about the history, the way patients describe seizures, that is important. A lot of YouTube videos are available for you to look at the seizure semiologies. So if patients are in remote areas are also making a video of the seizure and showing the doctor, they may be able to recognize, yes, this is a seizure. Once you make the diagnosis of a seizure, a health worker makes the diagnosis of a seizure, and there are recurrent seizures, then you have already diagnosed epilepsy. And then further, you just try to differentiate and see, does this patient have focal epilepsy or generalized? And based upon that, you can start treatments like I've told you. You do not need in every patient to investigate.
This is from Mr. Abdul Wadud of Rajshahi. Is sodium valproate preferable to carbamazepine in treating tonic-clonic epilepsy?
So tonic-clonic is a kind of motor seizure. Sodium valproate can be used to treat a tonic-clonic seizure. A tonic-clonic seizure, however, can either have a focal onset or it can have a generalized onset. So if a focal seizure becomes bilateral, then you say that it is a focal onset bilateral tonic-clonic seizure. This is focal epilepsy. In another patient, you can have tonic-clonic seizure, which was generalized at onset, which means that this person has got generalized epilepsy. So if you are asking me the best drug to treat tonic-clonic seizures of focal epilepsy, I would recommend carbamazepine or oxcarbazepine. And if you want to treat tonic-clonic seizures of generalized epilepsy, then sodium valproate may be a better drug. In women, if you are concerned, you may choose levetiracetam in place of sodium valproate.
Okay. The next question is from Dr. Kaushik Nath of Jorhat. Can we use gabapentin in focal seizures?
So gabapentin is a very, very weak anti-seizure medication, and we don't generally use it either in monotherapy or even in polytherapy. So it has very limited use. So in focal seizures, I would prefer that you try either carbamazepine or oxcarbazepine, or if your patient is not tolerating, you can try so many of the other drugs, including levetiracetam.
Thank you, ma'am. That was the last question. Over to you, Ms. Simi.
Thank you so much. Thank you for your patient hearing. And I think the wait has been worth. We have taken some more time, but I think the interaction part, the question and answer, it was very good to have all these important discussions put forward. So with this, we are good to end. But before, I would like to, there are a couple of things which we have to do. So there's a feedback form which is available, and you have to refresh the page to download your certificate of attendance for today's webinar. Just to remind everyone that next in August month, we have the webinar which will be focusing on managing common skin conditions in primary care. Recording of this webinar is available on BMJ's YouTube channel. It is Education from BMJ. Remember to follow us on Facebook and LinkedIn to get updates on the webinar @BMJ India. With this, thank you so much, Professor Mamta, Bhushan. I think it was an amazing lecture. We were able to get so much insights into one of the very tricky areas for physicians. So thank you so much. Thank you so much, BMJ. For everyone, thank you for signing in for today's webinar. It's BMJ India team signing off. Thank you and have a nice day.